Assalamu alaikum, dear colleagues. It's a pleasure to be here on this Sunday morning, and I'd like to thank Dr. Tahani and the organizing team for inviting me. So thank you to Dr. Mohammed as well for setting the context and making my life a lot easier. So we'll try and look at some clinical cases on how we can actually apply this risk stratification tool. Before I do that, these are my disclosures. And so to fast or not to fast really is a decision for a patient with diabetes based on, one, the fact that we appreciate that it's an obligatory religious practice. As Dr. Mohammed has already emphasized, a lot of our patients with diabetes don't see themselves as being sick, and they do not want to miss out on the religious festivities and the religious blessings that come with this blessed month once a year. It also indeed is a personal choice, and our role is, as healthcare providers, to try and bridge in between the obligation to fast and the patient's choice. So if the patient, as you've heard, is of a high risk and they still want to fast, then that's where we come in and see how we can help for them to fast in a safe manner. So the need for the pre-Ramadan education is really vital. It has to be focused on, first of all, looking at what the patient's risks for fasting are, what treatment modifications they're going to require, their ability to monitor, because if they're not able to do that, then you can't say fast if you're not able to monitor. It's like driving without having a speedometer in your car. It's also an opportunity to discuss the nutritional elements and physical activity that a patient might be able to engage in. And most importantly, to actually spell it out when they should break their fast. Because I've had patients that I ask in the clinic and they say, okay, have you had hypoglycemia during the fasting hours? And they say, yeah, 1 hour before breaking the fast, my blood sugar was 68. And I said, so what did you do? And the patient said, well, I went to sleep so that I don't do any other activity to bring it down further. So they need to know when they need to break the fast. Okay, so when should this pre-Ramadan assessment be done? It needs to be done at least 6 to 8 weeks before Ramadan, because then you know that the patient is going into Ramadan in a stable state where you've already optimized all their glycemic control, their blood pressure, hopefully their lipids as well. And as we've heard from the stratification tool, you need to have information on the patient's medical history, because it is going to be very individualized and different from patient to patient. So what other comorbidities do they have? What about their Ramadan experience? Because we may think, yeah, you stratify them, they're at high risk. Perhaps we would advise that they shouldn't fast, but I said, but doctor, I fasted last year. And of course, their ability to self-manage their diabetes is really important, or the sort of social support that they have. So I'm going to start with the cases now. And this is a 42-year-old teacher. She's had diabetes for the past 5 years. Her BMI is 27, and her most recent hemoglobin A1C 7.6%. She monitors her blood glucose once a day, but is willing to do it more frequently during Ramadan. She doesn't have any evidence of micro or macrovascular complications. Currently, she's on metformin. She's also on glycoside MR, and she's on a fixed dose combination of a basal insulin and a GLP-1 receptor agonist. Now, last year, she was not on the injectable therapy, and she managed to fast without any problems. But this year, she's a little bit more concerned, and she said, doctor, I'm a bit, worried because I'm on too much medication. Will I really manage? So then what we can do is, of course, look at the ADA-ESD consensus guidelines on the management of patients, assessing their key characteristics, then taking a shared decision, implementing the plan, and then reviewing that. But as we've said, the most important thing is first looking at what is her risk for fasting. And we've already seen the traffic light system: high risk, moderate risk, and low risk. And you don't have to remember all these, memorize all those elements in your head. We do have it online. And fortunate for ICDL, where Dr. Mohammed works, they've already incorporated it with their electronic medical record. So you just key in the numbers, the information, and it calculates the risk for you. But you can download it, you can have it on your mobile phone, and you can go onto the website so that you can actually then put in the information to get the risk for your patient. So going back to Hala, she's got type 2 diabetes, so she scores 0 for that. She's had diabetes for less than 10 years, so she's 0 as well. She's not had any hypoglycemic episodes. She is, however, on a basal insulin, and she's also, I don't know and she's also on, but the pointer doesn't work. And she's also on glycoside MR, and therefore she gets a point. Oh, thank you. And she gets a 0.5 for that. So if we look at the score on this page, her A1C, yes, is also 7.6, so she scores 1. So she's got 3 so far. Then we look at the other factors. She doesn't have any evidence of macrovascular disease. Her eGFR is within normal. She's not had any acute complications of diabetes, and she's willing to self-monitor her blood glucose during the fasting hours. What about the other elements? She's a teacher, so she's not going to be engaged in any physical labor. She lives in Dubai. We know that this year she's going to be fasting for less than 16 hours. She's not elderly, and she's not pregnant. And pregnancy here, we know that pregnant and breastfeeding women, irrespective of diabetes status, have the right not to fast, just as a reminder. So where does Hala sit in? She's within the low risk category of 0, since she has just 3 points, and therefore fasting for her is obligatory. She should be able to fast. We are obviously going to make adjustments, perhaps in her injectable dose and maybe the sulfonylurea dose as well, and we will discuss that in the next 2 lectures. But this is somebody who is at low risk and therefore should not have any complications during Ramadan. So let's look at another case, and this is Munir. He is a 62-year-old military officer who's had diabetes for 15 years. His BMI is 30, and he suffered a myocardial infarction about 6 months ago, but is currently not in heart failure. And his renal function has been stable over the last 3 months with an eGFR of 68. He's also on multiple antidiabetic agents. He's on metformin, he's on an SU, an SGLT2 inhibitor, and he's also on the fixed ratio combination of a basal insulin and a GLP-1. He does monitor his blood glucose once a day, and he's got an A1C of 7.3. However, he has experienced 1 hypoglycemic episode in the last 3 weeks. He too wishes to observe the fast. So now, having seen the previous case, just by show of hands, is this patient low risk, moderate risk, or high risk? Just show of hands. How many think he's low risk? Medium risk? Okay. High risk? A few. Okay. So that's the validation that survey that we had. Okay, so we can plug in the numbers. Type 2 diabetes, so he gets a 0. Duration of disease, so he gets a 1. He's had a hypoglycemic episode, so I've put in a 1 there. He's on a basal insulin, and he's also on the SU, so he's got 2 there. His A1C, however, is optimal at 7.3. He does have evidence of macrovascular disease, but he's quite stable, so he gets a 2. He's not had any acute complications, and he is willing to self-monitor. What else do we have? On this page, he scores 0 for all the elements. And therefore, as if you've all rightly guessed, he sits in the moderate risk because his total score is about 6. And therefore, fasting is preferred. The patient may choose not to fast if they're very concerned about their health. But again, we're going to discuss on what changes he's going to make in order to reduce his risk for both hypo and hyperglycemia. So 2 patients that I've already just shared with you. Very easy to do the risk scoring. You can do it on your mobile phone, or you can do it on your desktop if you're using your electronic medical record. You just then key in and then advise your patient accordingly. I also want to draw your attention to diabetes in the elderly, because we do have a substantial number of elderly patients. They've been fasting for years and years, and they would like to continue to do so. So I just bring in 2 patients again here. We've got Salim and Sheikha, both of them age 17. They've had diabetes for the same duration, 15 years, and they're on the same treatment regimens on a DPP-4 inhibitor with metformin combination. Both are hypertensives, and as you can see, the hemoglobin A1C for the 2 of them is identical. Salim is able to monitor his blood glucose 3 to 4 times a week, whereas Sheikha monitors her blood glucose daily at fasting, and then sometimes somebody checks it for her at bedtime, because she's already started showing signs of early dementia. Salim, on the other hand, is quite moderately active on his farm. He's not had any hypoglycemic episodes, neither has she. He does not have any cardiovascular disease, no evidence of macrovascular disease, and the kidney function is normal. And of course, he definitely wants to enjoy Ramadan fasting. On the other hand, for Sheikha, because now she's frail and she has early signs of dementia, the family is asking, should she fast? So let's start with Salim. The fact that he's got disease duration for more than 10 years gives him a 1. His therapy does not include any insulin or any sulfonylureas, so he scores 0 for there. His A1C is 7.5, so he gets a 1. And then we don't have any evidence of either micro or macrovascular complications. Neither has he had any acute complications in the last 3 or 6 months. And with the recommendations from the physician, he is willing to monitor his blood glucose. So he does work on his farm, but he does it for leisure rather than it being any sort of intense labor. He's going to be fasting for less than 16 hours, does not have any frailty, and therefore this gentleman only scores a 2, therefore low risk, and therefore he should be able to fast without much consequence. On the other hand, when we look at Sheikha, if you plug in the numbers, you also get duration more than 10, so she scores a 1 there. Her hemoglobin A1C 7.5, so she's 2. She doesn't have any evidence of complications, but the fact that she's got some level of impairment in her cognitive function and frailty puts her at a higher risk. So she's got, the score there is 6.5. And therefore 6.5, add with the 1.5 that we saw earlier, she scores 8. So she falls kind of at a very high risk, and therefore it would be reasonable to advise against fasting. So 2 patients who are almost identical in terms of their profile, but when you do the risk calculation, one is very different from the other. And this is what we're referring to as the individualization of treatment. It's no longer just eyeballing, because in the past we would have said, oh, Salim is 70 years old, he has type 2 diabetes for more than 15 years, Baba, don't fast. But when you actually look at it objectively, he can fast because he doesn't have any sort of comorbidities that would prevent him from fasting. But on the other hand, Sheikha might have hypoglycemia because of her cognitive dysfunction. She might not be able to tell her family that I'm feeling low, and the fact that she's already also quite frail. So what about, tips for our elderly population on their medications and the self-monitoring? They need to have that social support. So I worry about elderly people who are on maybe SUs and insulin and they're living alone or just have, a single attendant who's looking after them. Then I may say, yeah, you might fall in the medium risk, but I wouldn't allow them to fast. But if the family is around them all the time, they're able to recognize the symptoms of both hypo and hyperglycemia, then they can go ahead and partake in the Ramadan fast. We will be talking about the changes that individuals need to do for their medications. Diet and physical activity is also important. Of course, we don't want it to be a month of fasting and feasting, but as you've all probably realized, if you go into Carrefour or any of the supermarkets, the bottles of Vimto are right in your face. They've already put those out, anticipating that people are going to be consuming a lot of those. Physical activity, the Tarawih prayers also a part of the physical activity, and we encourage people to participate in that night prayer. Social circumstances, as I've said, are very important. Having that social support for particularly in the elderly to identify risks for complications is also quite essential. So in general, in principle rather, any efficacious medication upon which a patient is stabilized on, they can continue using during Ramadan. What we would want to avoid is any abrupt changes. So you don't want to be starting any medications during Ramadan or just a few days before Ramadan. We will talk about the modifications, of course. Usually no dose adjustments are required with the oral agents, but Dr. Mohammed is going to elaborate on the evidence around that. Usually we worry about sulfonylureas and insulin, and I'll talk to you more about that. How do we mitigate this risk? By making sure that every patient has that risk stratification done well ahead of Ramadan. You discuss their individual hypoglycemia risk and look at what their capacity is for self-management. Patients that are on insulin or sulfonylureas will need to check their blood glucose more frequently. And then most importantly, the patient needs to agree that I am going to break my fast, even if it's just an hour left for the time to break the fast, if they're having hypoglycemia or hyperglycemia above 300 milligrams per deciliter. The pre-Ramadan assessment is important. Equally important is the post-Ramadan assessment, because if you've told your patient that you need to make these changes during Ramadan, Eid comes, everybody's happy, you celebrate, and they may forget to go back to their pre-Ramadan doses and then come back to you again with deterioration in their glycemic control. So a post-Ramadan assessment is also important. So I'll summarize by saying that a pre-Ramadan assessment is vital for any person with diabetes who intends to fast, in order that we can evaluate their risk and offer them the management for them to be able to safely fast. Individuals who are on multiple antidiabetic therapies, just like the ones that I presented, will need to have this counseling, and it needs to be done at least 6 to 8 weeks before we get into Ramadan. So by now, most of the patients that you're seeing in the clinic should have already had, you should have already had this conversation with them. And of course, having the post-Ramadan follow-up is just as important in order to reassess their treatment regimen and to discuss what their fasting experience has been like. I think I have lots of time for questions. I'm ahead of time. So I can take a few questions if there are any. Otherwise, I'll invite Dr. Mohammed back on the stage, and then we can do the panel discussion towards the end. Thank you very much.